Welcome to Healthcare IT Today. I'm John Lynn, together with special guest host Brian Eastwood. The world of technology and healthcare are ever changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news, meshed together in new ways which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we're going to be discussing telehealth's next chapter. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Brian_Eastwood. Plus, check out our 19 years of health IT content at healthcareittoday.com. Welcome, Brian. Excited to have you as a guest host.
Oh, thank you for having me, John. Really appreciate it.
Yeah, well, I mean, you've worked on Healthcare IT Today for too many years now. I don't even know when we first started.
I
It
think we're
even
coming
did
up on about
Sway Health
four.
stuff.
Yeah.
Yeah, it just means we're getting old. I think that's what that means. But excited to have you on. Colin's off gallivanting around Europe, so I needed a nice replacement. And I don't know if we call this an upgrade, but appreciate you coming on.
No, again, I'm glad to be here and a little jealous of Colin's travels, but
Aren't we all? Aren't we all?
yeah, happy to fill
Well,
in.
the inspiration for this episode definitely came from an ebook that you put out on your site that people can purchase. It's called Telehealth's Next Chapter, a tale of volume and value. Love it. I love the second one always is what captures you, right? But people
Mhm.
can go check that out at brianeastwoodwrites.com. You're putting it half price for people that are listening.
That's
So
right.
yeah.
Yeah. Yeah, so I wrote the ebook just, I wrote a blog a couple years ago and a lot of people said, "Oh, if you added some stuff to this, it would make a good ebook." And I decided to take them up on that challenge. It took a while, but here we are.
Well, I mean, it's interesting for those that don't know you. You've been a journalist. You worked at conferences doing content.
Mhm.
But my favorite is especially in regards to the ebook, is you worked at Chillmark Research doing research stuff. So, yeah, I guess you're spanning your whole spectrum of your career.
Yeah, and and I've been talking a little bit about the process on LinkedIn, and one of the things I pointed out was I kind of missed doing this like longer form kind of writing, which is a lot like what I had done at Chillmark, these sort of longer in-depth reports where you're not just you're not just reporting, which is helpful. It's good to be able to use that journalistic skills to create some content that way, but also doing a little bit of analysis and then helping people figure out what that all means and how it will impact the work they do every day, regardless of what sort of sector of healthcare they're working in.
Mm. We might have to get you at Healthcare IT Today to do our ebook since you love the longer form. Anyway,
Mhm.
it's not my favorite.
Yeah, it's for some reason I like it a lot. I mean, I have a graduate thesis in history, which is like 100 something pages, and like I think four people read it, my three advisors and my dad.
I was gonna say not even your wife. I mean, she came
No,
later, but that's all right.
well, I often say to her, I'm like, if you're having trouble sleeping, I'll just go grab it. And
That makes sense. Well,
mm,
let's kick it off. I mean, what do you say is the state of telehealth today? I mean, it's been up and down, it feels like, but what do you say? Where are we at today in telehealth?
I think today, in looking at the data from the organization called Fair Health, which looks at a lot of like, sort of commercial claims data, and there was that spike that happened in the summer of 2020, quarter of the, spring and summer of 2020 during COVID. And then it kind of dropped off and it flatlined for the last like 4 years. And, I think what's happened is telehealth seems to have settled into, sort of a handful of use cases where people have agreed this is where it should be. This is where it makes sense. Behavioral health, um, kind of chronic care management in certain settings, typically like Kaiser and the VA. Um, and the sort of the tele ICU, teleradiology, telecardiology model, particularly in kind of rural settings. But beyond that, it's not really seeing the kind of usage that I think we all thought we might see, both when we were you know prognosticating about digital health and telehealth 10, 15 years ago, those sort of like those Star Trek tricorder images. But even sort of, in the height of telehealth, when, you had all these organizations, and I remember writing articles where technology leaders were like, we truncated from like years to days our like innovation strategy. And then it just kind of got left on the table after that. But, I think we've seemed to have settled on these handful of use cases. Um, the I don't know if controversy is the right word for it, but all that activity around like GLP-1s is really fascinating.
Mm.
It's not so, admittedly not something I dove into too much in the ebook, but I've been watching it and writing a little bit about it for some other folks too. And it's just this intersection of that has been really interesting. And I think it points to a lot of the reasons that folks have been a little apprehensive about telehealth because particularly when it comes to like GLP-1s, it's got a little bit of those Wild West characteristics to it, where some of the folks who are practitioners are not as stringently regulated as others, and you can kind of see like a little bit of a pushback of that as like a model for telehealth. But it's generally like in this place where there's a few places or sort of there's a few use cases that seem to make sense. And there's a lot of areas where folks are kind of like, we'd like to do this, but there's still so many things we need to get right before we can try. Like the licensing and credentialing and who's going to do what and how much will they get paid for it and will they get paid at parity and will patients continue to do it? Uh, so it's just very, to me, it's an interesting time because there's a lot of directions where that things could be headed, but there's also a lot of like dominoes that need to line up first.
Yeah. Well, I mean, as I listened to you describe it, you described, oh, telehealth is working and being used where there's a business model that makes sense.
Hmm.
Kaiser, totally makes total sense. They want to
Hmm.
reduce you actually coming to the office, right? The VA, that
Hmm.
they're paying for it regardless. So if it costs less for them to do it in telehealth and it's good for the veterans, that's great. The GLP-1s is maybe a second category, which I would also throw in with like the blue pill and all
Hmm.
the Viagra and Cialis and stuff like that, right? Where it's like,
Hmm.
well, telehealth is used kind of to get the drug, and it's almost this rubber stamp, which is going through all sorts of lawsuits. We'll see where that
Exactly.
ends up, lying. I think GLP-1s feel like they're in a kind of similar category. We'll see if it does follows the same path where they're just chasing the dollars and kind of this rubber stamp pharmaceutical thing. And then you're like, well, why isn't it just over the counter if everyone just gets it if they go on? But yeah, so that's like a second category. Then to me, I actually think that there's maybe a third category of like low hanging fruit that like all these employers are offering this
Mm.
like free telehealth visit, but we only do these six things. And so it's like,
Hmm.
yeah, maybe in many cases it's almost more of like a nurse practitioner. They do a very small subset, but you could do it. Ironically, we used it in our family recently and it worked really well. It was like got us what we needed. So that was actually pretty cool. But I'd actually say, who the biggest user beyond those business models that you described is? It's actually doctors that care about their patients in a big way. Like, we
Right,
had an
right.
OBGYN that's like, hey, you need to come do this follow up. But guess what? It's going to be 30 seconds of me telling you the results of this test. So why are you coming to the office? Let's do it on telehealth, right? Like, it was out of the kindness of that doctor's heart that they did it because they knew that was what was best for the
Hmm.
patient. It wasn't a good business model for them necessarily. It would have been easier to say, come into the office, but they were willing to do it because they knew it was right for the patient. And so they did it even at their own expense in many ways.
Yeah, I personally have seen a little bit of that too. I have a 4-year-old, and I think any parent, particularly when they get fairly young, spends some nights or mornings on the phone with the pediatrician, and the same thing there where there's situations where they're like, it's almost their first option is let's see if we can work this out over the phone so you don't have to come in. Or so if you do need to come in, you're in for 15 minutes and you're not, waiting with your sick child who has no idea what's going on.
Yeah.
And so, but you're right, it tends to be those providers and it tends to be those provider organizations who do have that model of caring, and the afterthought is how much they're going to get reimbursed for it, or
It's hard to say because you don't want to like be like, hey, you doctors that don't offer telehealth, you're jerks, right? Like,
Mhm,
like which I don't think it is that. It's that the model doesn't apply, right? I mean, I wrote an article a number of years ago. It's like, why hasn't telehealth been adopted? And my answer was
mhm,
the telehealth model is an improvement for the patient. It's often better even for the payers. They're fine with it. But for the doctor, it doesn't change anything. The
right.
documentation requirement's the same. The reimbursement is the same or possibly less, right?
Mhm,
Like the time you spend with the patient, the same. Like it doesn't actually impact the flow for the doctor. So, like when I look at it and I say, well, COVID spiked, and why didn't the usage of telehealth during COVID, when
mhm,
telehealth usage was at its highest, why did that not last? And my answer to that is telehealth from the doctor perspective is the same or worse of an experience, right? And
mhm.
so, like the doctor really does have to have that patient perspective that says, okay, this may not be better for me, but it's better for the patient, and that's why I need to do it. And so, that's a hard sell for any doctor, and I don't hold it against them, right? Like, would you, if I told you, hey, Brian, I'm going to pay you the same or less, and you're going to have to do something harder for me on healthcare IT today, are you going to be like, yeah, let's do that? Like, no, it doesn't make economic sense, right?
Yeah. It's interesting as we were talking about that. I found uncovered sort of an interesting data point when I was doing this research, which was that um, it was a study from the Kaiser Family Foundation had kind of been looking at private insurance claims as during the pandemic, and they noted,
Mm-hmm.
oh, the insurance payments were approximately the same, but the vast majority of the claims were, evaluation and management codes, which according to, their data paid out about $100 for a visit, and a 60-minute psychotherapy session, which paid out for, $120. So it's not only is it sort of that low-hanging fruit, it's inexpensive low-hanging fruit necessarily. And so, I think to that point was that there came that realization that this isn't super sustainable if we continue to do it this way. We're not going to be, with those sort of added layers of complexity that come with a telehealth visit, we're not going to be able to keep this going. I also think, economic pressure on a broader scale started to kick in around the time that folks, organizations and people were kind of emerging from the pandemic. I point to, like, to me, sort of the turning point was like spring or summer of 2021, right? That was the point where, folks who were going to get vaccinated had gotten their vaccines. And so it was sort of this collective sigh of relief that this healthcare system could be breathing. It's like, okay, we 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 we've gone through the worst of this. And in my mind, like that was the time to sort of reevaluate and be like, okay, we set up all this infrastructure. Now, what can we do with it? Like, how do we incorporate this into the work that we're doing? And I think I don't know if folks were just kind of fatigued. I don't know if they wanted to kind of get back to business as usual. Maybe they had to because they needed the in-person care and the higher reimbursements that came with it. And I think that had played a big factor in it. And I also think a lot of folks just had some catching up to do, right, in terms of that interpersonal relationship with their clinical team. And that can be hard to do virtually if you're not used to it. And for some patients, it was probably okay. For certain use cases, I mentioned, behavioral health, obviously. Another interesting tidbit was like chronic care management within like Medicare ACOs, where folks are like, oh yeah, we can keep doing this. Like we can continue to support this. Because in that case, like these patients are going to be coming in anyway. Like they're folks in a Medicare ACO who are having multiple chronic conditions managed. We're going to see them a lot anyway. We might as well transfer some of that to telehealth so that, make the most of those in-person visits. But, beyond that, I think a lot of care just returned to business as usual. Just
Yeah, I
because.
think you're right too. We missed that opportunity. That was the opportunity to say, wait, do we want to go back to how we always did it? Instead, they said, oh yeah, let's go back because we're excited. We finally can do it, and they're vaccinated. They can come to the office. The rules have changed. We're good. Let's go back. And yeah, that's really interesting.
Yeah, and in a way, it's hard to blame folks. Like just as you know, to your previous point, like if you have these two options that pay you the same amount and one requires a lot more work, you're going to do the part that requires less work. And even if you're doing the thing that requires more work out of the goodness of your own heart, at some point you're like,
Yeah,
I need
it
this
doesn't
time
make
back,
sense.
you know?
Absolutely. Well, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and guest host Brian Eastwood. Today we're discussing telehealth's next chapter.
Yeah, so this was an ebook I put together, sort of amid the pandemic and everything that was happening. It really seemed like telehealth's moment in the spotlight had finally arrived. That moment that, for the decade prior to that, we've been talking about, virtual visits. But then adoption leveled off almost as quickly as it had skyrocketed and has kind of been pretty level for the last, 4 or so years. And this ebook I wrote attempts to explain why that happened and sort of whether there's like precedent for that, while also offering sort of a playbook of sorts to explain where and how telehealth could expand. And as the title alludes, it's a nod to both volume and value as a way to help or organizations boost access to care and also their own so adding to the value they provide and also bringing in some revenue where it makes sense.
Awesome. Well, people should go check out your ebook. It's half price right now. You can check it out at brianeastwoodwrites.com and you can purchase the ebook. So that's awesome. I mean, it's great that you have the ebook. That people should all, go purchase the ebook and check that out, all the details. But what do you think is needed to kind of make telehealth's future bright? Like you said, I think we've flatlined, which, in a life that flatline's bad, right? Like in business,
Mhm.
flatline's probably pretty bad too, but I'd say it might be edging up slightly, but
Mhm.
it's so small you can't see it. But what do you think needs to change to happen to make telehealth, a bigger reality in healthcare?
Yeah, like a lot of deep thoughts I have, I think I was like out running when this happened, but it the realization that I thought I had was that where telehealth can succeed, I think, is as a way to as that sort of digital front door that we talk about a lot, with the recognition that the digital front door can be a lead to different like analog paths throughout the system. Like it doesn't necessarily need to solely lead to more, kind of, more virtual visits or more sort of messages or more, portal visits where you can use it to support the brick and mortar in-person appointments that you're doing. But it has to be but it has to be done in sort of a very pragmatic way. And I shared a few examples, where it's not, and I shared a few examples where it's looking at that sort of patient journey, kind of a long-term patient journey, and not just the folks who might call a couple times a year because they need Tamiflu or they think they have pink eye, but it turns out it's allergies, which is something I've done more than once lately. Turns out I developed a pollen allergy in my 40s.
Yeah,
Um,
I didn't know that
but
was possible either. I did the same.
yeah,
Allergies, but it was in my 20s, the 30s.
yeah. But it's looking at those, and I think some of them will make, I think some of them are things that people have probably mentioned before or thought of before. It's those, and I alluded to previously, it's like those kind of those check-ins, like post-operative check-ins or chronic care management check-ins, or where you're kind of supporting people who are already on they're already part of your clinical workflow. They're people you need to check in on, but you don't always need to bring them in to check in on it. In some cases, it's looking at some of those preventive care options. I know cancer screening is one of those areas where a lot of organizations are saying if we can screen people and you know you demonstrate to them that there may be some preventive services that they would benefit from beyond the screening. Like that's a great that's I think a great example of the volume and value thing, because there you increase the number of people you can reach out to, right? And the vast majority will get screened and be like, cool, I'm good for now. Some folks will realize, oh, maybe there's some action I need to take. And you can then sort of refer them. It's down, it's downstream revenue, but it's for high value sort of preventive care. And I think there's similar options for a lot of care management scenarios where you see folks who are at a higher risk of, autoimmune disease or, to that employer option. There's been a lot of movement around like musculoskeletal care where, organizations know that can be very like a hip replacement, knee replacement. Those things can be very costly. And if we can find people and get them into some sort of program with a balance of virtual care and kind of in-person care to help prevent that need for this highly invasive procedure that on the employer side is not only going to cost them a lot of money, but there's going to be that recovery time for that employer.
Yeah.
Why not look at it that way? And so there, really it's just thinking about those places where you like start to find the pieces of the patient journey within this longer workflow where sort of telehealth touch points make sense. And recognizing that there's also going to be a lot of those that you just shouldn't touch. And like
Mhm.
not trying to put the square peg in the round hole.
Yeah.
I
It's
remember.
interesting. Like I've seen the same with like wound care, right? On the
Mhm,
musculoskeletal, similar to that, where it's like it's a very profitable segment. And with the way, imaging and video has come, you can actually do wound care. But I would actually take a completely different look at it. You kind of said these are the places where telehealth makes sense.
mhm,
I actually would have taken a very different approach, which is how do we make a telehealth visit parity for the doctor, from a payment perspective, from a reimbursement perspective, from a licensing perspective, right? That, these are like the barriers to me that are holding telehealth back. In fact, here's a radical idea. What if we actually made reimbursement for telehealth higher than if you come into
mhm,
the office, right? Like, how would that like that's an interesting mind experiment, right? Like if you actually got paid more to do telehealth, how would that change doctors' perspectives
mhm,
on you coming to the office or not? Now, it does have the downside of like, hey, there's sometimes you do need the physical exam, and
mhm,
if you go to the telehealth, it's just a triage, and I'm still going to make you come in, and then I'm actually increasing the cost and stuff. But it's like that's almost what we need to really say, like, if you got paid more to do it, we would
mhm.
realize, oh, guess what? Doctors could do a lot more on telehealth than we realize.
Yeah, it's an interesting idea, and I think, I think it is something that would help. I think it would help really start to identify some of the use cases where you think it might work, but you're not sure. But the only way you're going to find out is if you try it. And so, like, if you get the stakeholders together, right? And I described this little bit, and I think you did a better job of it though. But saying, okay, you get sort of the healthcare system and the insurer, and perhaps a professional organization within that the particular specialty, and they say, okay, what areas make the most sense? Like what billing codes should we try to include in this? And how much higher do we need to make it? And if we make it that much higher, as a as a pilot or as this project we do for a calendar year or billing cycle, what will that how will that impact how will that impact utilization? And to your point, if with the boost we see, oh, people actually do come in, cool, let's keep doing that. And then even with the boost, most people are still opting for in person. Then you realize, okay, that was kind of just kind of brush that off. You're like, all right, well, that one didn't work, but maybe there's other, there's other sort of, there's other visit types within this cycle we can think about instead.
Yeah, I mean, it's interesting to think about, like, for the payer, it telehealth or in person doesn't really impact them either, right? Similar
Right.
to the doctor. So like, why should they pay more? Like, the only kind of way you could get in is say, hey, if you pay more for telehealth, then more people will get the visits, and then if more people get the visits, then they because the alternative is they're not being seen, right? Like that
Right,
there's a
right.
fair number of people who are just avoiding care because it's so inconvenient and they don't want to do it. If you make it more convenient, they'll get the care, which will save costs. Which anyway, there's a whole, payer dynamic.
Mhm.
Do they want to save costs? So there's a whole other, episode. But, so I think it's interesting. Would the payers be brave enough? And I'm always hesitant to say the word Trump in any episode, but you need someone like Trump that says, "Hey, this is right for the patients, let's do it," right? Like you almost need that kind of like, "Hey, I don't know what the consequences are, but this is right for the patients, so why aren't we doing this? And let's try it and see how that changes the dynamics." You almost need that mindset to make it happen.
Right. And I think it does, I think it does start with, finding the right place to do it and the places where it makes sense and where you've got that, whether it's, you know, true data, or you've got that, on maybe on a smaller practice level, you've got that anecdotal data to suggest this is where we know people are going to be coming in. And so let's focus on that. And that's where we know that that's going to start that chain where the more that people come in, the more they're gonna for telehealth visits. I think I've said the more they come in when I mean the more they log on. There we go. Yeah, the more they log on for these types of visits, the better care we're gonna be able to provide to them. To your point, and let's start with those. Some of the examples we talked about, and have yeah, there is a little bit of sort of courage involved there, but it's also like you said, doing what's right for the patient. And I think at the same time, when you look at what some of those reimbursement rates are, it's for individual visits, we're not talking a huge amount of money. And so if you're going to be, even if you're doing that at a pilot level, that's going to, that'll pale in comparison to like a kidney replacement in
Yeah,
terms of the
for
bottom
sure.
line. So
Exactly.
I think
And in
that can be
value-based care, you're going to have to do that, right? It
right,
feels
right.
like you're going to want that anyways, and so you want to facilitate that. So maybe value-based care is the hope for telehealth. That's interesting to think about.
Yeah.
Well, as we wrap up, what's your two-sentence prediction on the future of telehealth? Mine is more of the same and less policy changes. What's your prediction?
I think mine is, I think a slight increase in utilization, provided that it's done in the right spots within the patient journey. But otherwise, if not, then more of the same.
Wow. Well, this was awesome, Brian. I appreciate you coming on, and everyone should go check out your ebook, Telehealth's Next Chapter, A Tale of Volume and Value. You can purchase it at brianeastwoodwrites.com. It's half off right now, so be sure to check that out. And thanks for all of those who tuned into this episode of Healthcare IT Today. You can find more details about our show by checking out the programs page on healthcarenowradio.com. And be sure to share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm John Lynn with special guest host Brian Eastwood. Thanks for listening and have a great week.
Thank you.